Welcome guys. In this video, we are going to discuss about approach to upper GI bleed. This is the part of discussion of the emergency in the gastro medicine part. I will mainly use Harrison as a source and side by side take Schlesinger or any other important textbook in gastroenterology as the source for this lecture. Alright. Now coming to the first thing first, what do you mean by GI bleed? GI bleed is meant by any source of blood coming out from the gastrointestinal tract. Alright. So again, this is divided. And what is upper GI bleed? Based on anatomical localization, this is divided into upper and lower compartment. So the thing that differentiates between upper and lower is nothing but a ligament known as the ligament of Treace. All right. So if you can look here, yeah. So you can see diaphragm, the right crest of diaphragm is extending to the duodenojejunal flexure. Now this is the part of the esophagus. Here is the stomach which has been removed, part of the duodenum and continuing to the jejunum. Up to this duodenojejunal flexure, the right crest of diaphragm is extending and forming a muscular loop around and for ligamentous connection which suspend this flexure from the retroperitoneum. This is known as ligament of Treace. Alright, and this forms the demarcation between upper GI and the lower GI bleeds. Now how do the upper GI and the lower GI bleed present usually? Lower GI, that is the below the ligament of Treace, is you will always and most commonly present as a case of hematochezia. What is hematochezia? Hematochezia is fresh blood coming in stool. All right. Okay. Now, how do the upper GI bleed present? Upper GI bleed present mainly three distinct ways in clinically, most commonly being severe blood in the vomit or coffee ground blood in the vomit. So blood in vomit is the most common presentation. Now when someone is bleeding in their vomitus, they will ingest some amount of blood inside also. This blood gets metabolized and converted into a dark colored pigment which is passed in the stool. That part is known as melena. So what is melena? Melena is dark colored stool which is nothing but the blood which is ingested by the person. Secondly, beside melena, other presentation upper GI bleed can present is surprisingly yes is hematochezia. What was hematochezia? Hematochezia was severe and active blood in the stool. So how does upper GI bleed can present as hematochezia? For the cases rarely mainly when there is severe upper GI bleed and increased transit time in the GI tract, the patient can present in hematochezia also. Regarding melena, melena are usually from the upper GI source, that is the above the ligament of Treace, but sometimes it can be from the small intestine also. All right, it can be from the small intestine too. Okay, all right. Now once you know that these are the presentation of upper GI bleed and someone comes to you, you need to triage it to identify where to admit or whether to admit at all or not, go for OPD based treatment or not, or whether required ward management or ICU based management. So before that, you need to know what is known as severe GI bleed. So severe upper GI bleed is meant by if the bleed is so much that it leads to the presentation of shock or cause drop in the hematocrit volume or drop in the hemoglobin value. So what are the parameters in it? For example, drop in hematocrit should be more than 6% or drop in hemoglobin by 2 gram TL or the drop in hemoglobin is warranting for PRBC transfusion minimum around 2 unit PRBC transfusion. Now these are the cases when I will consider to be a severe GI bleed. All right. Now to triage the patient, you are getting very easily that if a person, someone is coming with severe GA bleed, you need to admit the patient into intensive care for proper management as well as monitoring. All right. Now, if someone is coming with non-severe bleed, for example, someone is coming melena as well as hemodynamically the person is stable, there is no drop in hemoglobin in the blood parameters, that is routine parameter is coming to be normal, you can obviously go for OPT based management. Whereas if condition like, for example, there is acute bleed but the patient is hemodynamically stable, you need to admit the patient. But whether to admit in ward or in ICU is based on your clinical judgment. Alright, same thing that is from the Schlesinger. So it says if there is large bleed, unstable hemodynamics, that is if there is cases of severe GA bleed, you need to admit the patient in intensive care. If there is non-severe bleed like mild bleed or infrequent melena and patient is hemodynamically stable, there is normal blood parameter, OPD based management can be tried. In other cases like acute bleed, hemodynamically stable condition, it is based on the clinician's judgment. Alright, okay. So when you know what to do with the patient who comes to you with upper GI bleed, now you need to go for as well as diagnostic approach as well as therapeutic approach to find the cause and go for proper treatment. Remember, this is a case of emergency. So diagnosis should not hold your treatment and saving the life of the patient. Both will go hand in hand. So what is the first step in any diagnostic approach is, any diagnostic approach first step involve history and physical examination. What should history focus on? History should focus on to find out the etiology behind the bleed. So what are the causes that can lead to this bleeding? So if we draw this diagram, this is the ligament of Treves which is suspending the duodenum and jejunum. Anything above is the upper GI bleed. So what are the source possible to upper GI bleed? It can be esophageal source, gastric source or duodenal sources, right? So esophageal source like esophageal ulceration. Ulceration can be up above as well as the lower part. It can be due to the mucosal tear in the lower part of the esophagus known as the mallory OS tear. There can be case of variceal development in the GI tract seen in case of chronic liver disease, as well as it can be due to any other pathology. For example, there is development of peptic ulcer diseases, gastric ulcer as well as duodenal ulcer. It can be even due to development of malignancy. Peptic ulcer diseases. All right. So what are the important point in history that will help you identify this etiological point? So what are the clinical clinchers for esophageal ulceration? Person with esophageal ulceration will complain of acid reflux requiring multiple PPIs. There can be history of dysphagia or odynophagia, that is painful swelling. Odynophagia in case of esophageal ulceration. Mallory OS tear is seen in the person who tries excessive vomiting against the force. For example, in case of retching. Alright. Now this tear can be due to violent coughing as well. This is mainly seen in alcoholic patient. Now, if there is peptic ulcer disease, you know there are two type of mainly peptic ulcer disease. So what is initial symptom that will signify peptic ulcer disease? There will be history of heartburn, might be associated risk factor like history of NSAID intake or stigmata of H. pylori infection can be present. And once in suspect peptic ulcer disease, you need to ask about the relation with food. If it improves after food intake, if it is pain improves, that is pain decreases, it signifies to be duodenal origin. Whereas if pain increases after food intake, it signifies to be peptic ulcer, that is of the gastric origin. All right. So gastric ulcer. Now regarding the malignancy part, malignancy patient will present with cachexia, weight loss, and dysphagia. Dysphagia is, that is difficulty in swelling. In case of malignancy, it will be progressive dysphagia. That is the classical description. Progressive dysphagia, initially to solid, then to liquid. All right. Regarding the varices, varices developed in CLD. Remember, upper GI bleed in CLD is sign of decompensation. So what are the other sign of decompensation? Other sign of decompensation is development of ascites, development of jaundice, or development of hepatic encephalopathy. All right. So if the person presents in a state of altered behavior, somnolence, there is heavy grade jaundice on clinical examination itself or ascites on examination, it strongly suggests what chronic liver disease to be the etiology. All right. Now, with this history of presenting illness, next step involves to seek the history, past history, as well as the medication history. Some important point in past history includes, for example, if the to check whether the patient is diabetic or not, or there is history of chronic kidney disease, hypertension, as well as aortic stenosis or hereditary disorder, which increases the risk of angio dysplasia. In personal history, both smoking and alcohol history becomes important. Smoking, as you know, increases the risk for gastroesophageal reflux diseases, malignancy, etc. And alcohol increases the risk of Mallory, OSTR, as well as alcohol related chronic liver disease. Here it should be remembered that Mallory OSTR, being a mucosal tear, usually has a very good prognosis in nature. Alright. Now, what are the important drug history you need to treat? Important drug history, for example, you need to know about whether there is history of intake of aspirin, NSAID, COX-2 inhibitor, etc., which promotes the development of peptic ulcer disease, or was the person taking any medication which increases the risk of bleeding, for example, taking warfarin like anticoagulants, or antiplatelet, for example, like clopidogrel, or aspirin for any other cause. All right. So these are the important history. Also in history of drug, you need to check for some causes, like for example, if the patient was on iron supplement or not. Why need to specifically ask for iron supplementation? For example, if patient comes with a complaint of only melena, which is a part of upper GI bleed in the outpatient department, remember iron can give a false black color in the stool representing to be a melena. So what is the classical textbook description of melena? Classical textbook description of melena is black terry stool sticking to the pen. In iron supplementation, all these features will not be there. Instead, only black stool will be seen. Alright, okay. So once with this history and basic quick history grasping, you got into the idea that what can be the possible etiology of the disease. You need to start management side by side. All right. So, what are the things that is involved in management of this patient? Remember, it being an emergency presentation, if the patient comes in severe GI bleed, obviously first is A, B, C, D, that is airway, breathing, circulation, and disability limitation. So, what are the things that you need to do for circulation part? For circulation part, we need to ensure two large bore IV cannulation has been done to give fluid as well as medication if at all required. So, fluid target is IV fluid normal saline. It is given with a target of systolic blood pressure to be maintained more than 100 mmHg and heart rate to be maintained less than 100 per minute. If there is ongoing bleed suspected and there is severe bleeding signs present and orthostatic hypotension and as well as the low BP is not getting controlled with IV fluid normal saline administration, you can go for PRBC, fresh fusion plasma or platelet based on the condition of the patient. Now, the target for this is to maintain a hemoglobin of more than 7 and platelet count of more than 50,000. All right. Now, if a person comes with altered behavior, when will they come in altered behavior? If the person was a known case of chronic liver disease, came in upper GI bleed precipitating the hepatic encephalopathy, and for example in stage 3 or 4, person will have altered behavior in stage 3 as well as comatose in stage 4. So in such cases, in CLD patient, it is advisable for airway management to maintain the patency of the air to go for ET12 tube placement prophylactically, mainly in the elderly age group. All right. Okay. So with this thing, next involves to start initial medical therapy. Initial medical therapy contains PPI to be given. PPI is given initially as an infusion for 12 hours, and based on the endoscopic report and imaging and what was the diagnosis, actual diagnosis there, PPI doses are modified later on. Octreotide, if clinical history and examination was supportive of chronic liver disease, octreotide is given initially bolus followed by infusion. If bleeding doesn't stop in the emergency after thorough resuscitation, bolus dose can be repeated as well as. Alright. Now, blood being a very good culture media and GI tract contain of lot of pathogen, so there is high chance of growth of pathogenic organism in the tract and ending up into the bloodstream resulting into bacteremia. Therefore, empirical antibiotic should be given to all patients of upper GI bleed. Now, when to perform endoscopy? Endoscopy is never urgent, remember. First step is obviously resuscitation followed by endoscopic management. Now, in endoscopic management, it involves both diagnostic as well as therapeutic part. So, what are the diagnostic as well as therapeutic part here? What are the things that we can see actually? We can see very active blood or some form of disease that has very high chance of recurrence. For example, clot or non-bleeding visible vessels can be seen, which is a major stigmata of recurrence of bleed. We can see instead of active bleed, we can see to be oozing present, oozing of blood, or there can be flat topped ulcer, or even sometimes surprisingly normal finding can also be seen. All right. So based on this condition, how they present, therapeutic approaches differs. Now this is again from the UCLA Care database taken from Schlesinger, showing the causes of the severe upper GI bleed. You can see clearly peptic ulcer forms the major chunk, followed by esophageal ulcer. So most common cause of upper GI bleed is peptic ulcer disease. Most common peptic ulcer followed by esophageal variants. All right. Okay. Now, this is a prognostic scoring known as M65 score, determines the risks of in-hospital mortality from the upper GI bleed. So, what are the parameters in the M65 score? It contains A for albumin, I for INR, albumin, INR, M for the mental status, S is systolic blood pressure less than 90, and A age is more than 65. Each having 1 point. With if there is everything getting 1 point each, you will find total score of 5. That is in hospital mortality rate of 25%, around 25%. What does it mean? So if there is elderly person coming in the low BP, altered mental status, INR to be reached, albumin to be low, and coming in upper GI bleed, mortality is significantly high. It is around 25%. All right. Okay. So this M65 scoring, this helps in stratification, but is not so much urgent. Should be not be done in urgent basis in emergency department itself. It should never be done. Management and therapeutic approach is the primary goal in upper GI bleed. Stratification and risk identification is the later. It can be done on later period when the patient has been stabilized too. Beside M65 score, there is another score known as the Rockwell scoring system. This is most commonly used. It uses the parameter like age, pulse rate, and systolic blood pressure. So what does this two signify? This signifies shock, present of comorbid condition. Among comorbid condition, renal failure, hepatic failure, and metastatic cancer has the highest significance. This is the reason also this renal failure and hepatic failure increases the chances of upper GI bleed. All right. And what is the diagnosis? As said earlier, Mallory-Weiss tear has the best prognosis as it is only a mucosal tear only. So score of 0 is given in Mallory-Weiss tear. All benign score is 1 and malignant lesion score is 2. And based on endoscopic findings, score 0 or 2 is given. All right. Okay. So coming to this management part. So once again, what we can see in endoscopy. In endoscopy, we can get normal or flat topped ulcer, active blood, active bleeding vessel, any vessel which is not bleeding currently but signifies that vessel which is dilated and visible, means there is chance that it can go into bleeding later period. So non-bleeding visible vessels and clot. These three means there is high chance of bleeding, and endoscopic basis hemostasis should be achieved in such cases. All right. How it should be achieved hemostasis endoscopically? Endoscopically, hemostasis can be used with application of hemoclip as well as giving electrocautery or adrenaline injection. All right. Now there can be chances of oozing as well. As in case of oozing, treatment option involved application of hemoclips. Now in flat topped ulcer or almost normal cases, what is done? Patient is discharged on proton pump inhibitor and nothing specific management is required in such cases. In case of active bleed or non-bleeding visible vessel or clot, proton pump inhibitor infusion should be continued for minimum 3 days, followed by twice a day BT dosage of PPI. In case of oozing or hemoclip, we can go for as early as possible normal diet, restart of the normal diet, and PPI twice daily. All right. So that's what is mentioned in Schlesinger. There is major stigmata of bleed, high dose of PPI followed by oral PPI is given, and endoscopic hemostasis is achieved with epinephrine injection or electrocautery. If there is flat spot or clean based ulcer, oral PPI is enough and you can discharge as early as possible. If there is oozing, hemoclip is achieved or thermal hemostasis is tried and followed by oral PPI twice a day. This is a classification devised by Forrest based on endoscopic features. So what does it says? It says three things mainly. So it defines whether it is active bleed or non-bleeding finding, but there is a chance that it was bleeding earlier, or a clean base. So class 3 in the Forest classification, stage 3 signifies clean beast ulcer. Stage 1 signifies active bleed. It can be spurt of blood or it can be due to oozing. Alright. So 1A and 1B. 2 is again divided into 2A, 2B, 2C. 2A is non-bleeding visible vessel, 2B is clot, and 2C is flat spot in ulcer crate. Alright, okay. This is the Forest classification. Here you can see oozing of the blood from the image shown here, and two hemoclips are applied. What is this dose? This is actually due to oozing, so this is nothing but stage 1B based on Forest classification. So that's all about management and treatment on approach to upper GI bleed. This is the first class on the emergency topic of gastroenterology. We'll cover the later classes too. This is again in the Schlesinger, all the things that the approach I have just discussed right now. So severe upper GI bleed, first step is history and physical examination and making a provisional diagnosis. At the meantime, treatment should go on to manage, like for example, routine blood investigation panel, if blood infusion, PRVC transfusion requires or not, fresh frozen plasma or platelet transfusion requires or not should be decided. And if this is unstable condition, admission to ICU is warranted, whereas if there is stable, admission to normal bed, standard hospital bed can be done. Now, with hemodynamic resuscitation ongoing, we do consider it for high dose PPI therapy if peptic ulcer disease is suspected, along with empirical antibiotic coverage and octreotide plus minus based on the liver status. Now, following which endoscopy is done to find out the cause, and along with it we go for the specific management based on the